funny this presentation is.
Closely mimics like solid tumor, especially when the tumor burden is to best efficacy and best safety profile and at a fraction of cost as compared to the Western CAR-Ts. So 85% complete response in relapsed refractory ALL. This is not a data for PFM protocol in upfront. This is the data for relapsed refractory ALL, and with 62% overall response in NHL with progression-free survival, median progression-free survival over 12 months is not reached in both ALL and NHL cohort, and you have more than 500 patients data right now. With this extensive and robust data, we should be grateful, and we are grateful to you for producing this product at an unmatched affordability. I think, can we move to next slide, or Dr. Jaideep sir, you want to take over from here?
Kunal, thank you very much. It's a very good, as usual, a very good representation of the product that is being manufactured by ImmunoAct. So we will continue with our presentation. Now, can we go up on this? Presentation. So we will continue with the presentation here. We're just going to move out a little bit. We'll come to CAR-T, back to CAR-T again, but we'll just move out a little bit and talk about, it's a little bit funny, this presentation is, but I thought it gives us a philosophical edge on Sunday morning to think whether what we are doing is appropriate or not. And the idea of the presentation first came from Peter Gale, Robert Peter Gale. I don't know whether many of you have met him or not, but he's a man who, teaches us to question everything. So that is something which I learned from him. All the, his furosemide needed for heart failure. Have we ever questioned? We have never questioned that. So, these are small questions that we take for granted, small facts that we take for granted, but maybe it is the time to question those beliefs. And one of the things that he was very so one of the things that he was very against is blindly following guidelines. And what are guidelines and how it can help us, and sometimes they don't help us also. So today, as in the morning, I was speaking with Professor Senwin, and we were saying that we really don't know anything. So the CAR-T concept, the CAR-T field that has come up, the bone marrow transplant field that has come up, we claim that we know a lot, but actually we don't know. The hematotox score that we are doing gives us nothing. Even with a low hematotox score with patients with, it is definitely a hematotox score doesn't work with patients with leukemias. It might work with patients with lymphomas, but it is horrendous if you try to bring that data in the leukemia picture. So actually, going through these guidelines and recommendations, you really need to take a step back and think as to what you are believing in. And Robert Gale was one of the pioneers in bringing skepticism in all these beliefs. I was involved, I was a registrar at the Royal London Hospital at that time. It's a funny story, and we were involved in providing the logistics as junior doctors do when the guidelines for L-Thrombovac, when the second line, so they were trying to put it in the guidelines. So they got experts from all around the world and they were meant to sit in a room and to discuss their recommendations. And we were making sure that they have their rooms, their toilets are clean, they have their tea and coffee, and in the meantime also see what recommendations they were giving. And the recommendation is actually by the pharma company and by nobody else, really. So that is something we really need to take it in a pinch of salt, especially if you're going to have guidelines and recommendations which are backed by a business interest. Please be very, very aware of what you are believing. At a point of time, people used to say that you have a clear throat if you smoke. And some of my colleagues, still follow that and went downstairs to have a smoke in the morning before coming up. But that actually really doesn't work very well, as we know of now. So guidelines changes, beliefs change, and as we get more and more evidence, as we think we know more, we start going against some of the preaching of these guidelines. So one of the very important beliefs that we have is based on this, which is our venetoclax story, and the venetoclax and the FLT3 story, really the sorafenib story, and we'll come to it. So just for for the juniors, the mitochondria was actually a bacteria, and then it came to come into the the eukaryotic cell, and together it brought quite a lot of enzymes along with it. And some of the enzymes are needed for apoptosis or killing of the cells. And now, if you are going to add venetoclax to, let's say, this drug called sorafenib, and even if you are not FLT3 positive, what happens? So, we have been told that we use only sorafenib in the FLT3 positive group. But here you can see, apart from that, apart from BCL2, there are other enzymes, namely the MCL1. And here, sorafenib is a very big inhibitor of MCL1. So actually, we can use sorafenib in any acute myeloid leukemias, whether they are FLT3 positive or not. And if you put venetoclax with it, it works even better. So this is some of the data of our hospital patients who have had an allogeneic transplant, and we have used sorafenib in all our AML patients post-allogeneic transplant, regardless of their FLT3 status. And of late, we can see that we are using venetoclax, azacitidine, and this was a very interesting patient. In fact, this was a patient who was initially treated at the TMH Hospital, Mumbai, and then through many other channels, if I say channels, came to us. Tushar is his name, is back in Mumbai, and he had a disease which was FTGRF1 positive, so a fibroblast growth factor 1 positive. So we used ponatinib, and we can see that he had a multi-lineage acute leukemia, and we have treated him with sorafenib, venetoclax, azacitidine. We have given him MDLIs, memory cell along with venetoclax is a very good drug for maintenance of acute myeloid leukemia. We have used it post allogeneic transplant, and if my juniors are clever enough, they have got a ready data, they should be able to publish this. The next belief that we have is that stem cells, and when we talk about hematopoietic stem cells, we believe that all these hematopoietic stem cells are going to show up the CD34 antigen. And you see CD34 antigen is shown up in many cells. We know the endothelial cells. So if we do a trophine and if we stain it with CD34, we know that it stains the blood vessels. So the endothelial cell membrane is definitely CD34 positive. So really, can we identify the stem cells with CD34? And is there only one type of stem cells? I don't think so, and we have now come to see that there are long-term stem cells, short-term stem cells, and there are progenitor cells, which all the cells are needed to repopulate a marrow after a bone marrow transplant. So the question is, can we accurately identify human stem cells with CD34 positivity? And most probably not. In mice, what we see is that the stem cells, when they are born, they are not CD34 positive. Is it the same thing for human beings? We don't know as yet. But what we know is that there are many cells which are CD34 positive, which are not stem cells. Yet we count the CD34 positive stem cells. Yet we run out of reagents for counting the CD34 cells, and we try to get them. But that is the only way we can look into this, because we don't have any better way of identifying the stem cells. And is it only the stem cells which are responsible? So this is very interesting, and you can see that if you are red, you have got the stem cell capacity, and you've got varying degrees of stem cell capacity of many cells. And not only the CD34 positive cells, but many other cells, and many of them will be the recipient derived also, which are going to help us repopulate the marrow. So what are the cells which are responsible for a recovery? One is, the data is largely consistent with mice, and really we don't know what type of cells they are, but not all stem cells contribute equally towards hematopoiesis. And how do we know this? We know this very, very glaringly by this thing called the haplocord transplant. So what we do is we do a cord transplant, but because you know that a cord will take a lot of time to engraft, so we add a haploidentical transplant along with that. So on day 0 we do a haploidentical transplant. On day +1 we do a cord transplant. And you can see as we go up, by gradually around 3 months time, we find that the cord starts taking over the haplograft. So with the haplograft we get early engraftment. So the infections and all those things are prevented. With the cord, when it starts taking over, we really don't need to bother about the graft-versus-host disease at all. So this is a very interesting concept. It's called the haplocord transplant. And we have made it even more interesting by this. This is called the Save the Sibling. So this baby has got, let's say, thalassemia, or a genetic disorder, or a malignancy, for which we can wait. So what we do is we ask their parents to have another sibling, but this time through IVF, and we're going to have pre-implantation diagnosis. So we are going to have a sibling which is going to be a full match to this kid who has got thalassemia, and thalassemia free or the genetic disease free. So the parents have another kid, and that kid, when that kid is born, we collect the cord, we collect the umbilical cord of that, and this is stored by a company called Cord Life. And what Cord Life will do, so these are the Cord Life people, what they will do, they will collect the cord and they will give it to us. But my experience is that Asian cords don't have that amount of stem cell numbers in it to do a proper transplant, and the engraftment time is almost a month. By that time our patients die really. So what we do is that not only we take the cord, but we also take some haploidentical cell from the parent and do a haplocord transplant. And the best thing is that via insurance, Cord Life pays the money for the transplant. So, this is also how health economics come into play. So, with a limited amount of resources, the parents get a second baby who is definitely disease-free, and with the cord, we are able to do the first transplant. So, saying that, we have done the first transplant, we have done our first patient, Akshay is his name, the chap is from Bangladesh. So, we have done the first haplocord transplant in the Save the Sibling program, and he's going to most probably go home tomorrow or Tuesday, and depending on what our astrologer says. So you see, this is an excellent way of doing the transplants. But remember that there are certain things which you need to keep in mind, that when you give the post-transplant cyclophosphamide, how much cyclosporin you give. So there is a little bit of a fine-tuning for this. But what it shows is that there are different type of stem cells, as in the cord and in the haplograft, which will behave according to its own characteristics. So we cannot do anything. The cord will engraft later, the haplo will engraft faster. And it will depend on which one has got a more powerful mojo as to which one it will survive. Generally speaking, the cord survives, generally in the majority. There are some transplants where the haploidentical graft also survives. Not a problem. Not a problem for the patient at all. Because both of them will be, if it's a thal, it will be a thal trait, either the haplo or the cord. Now this is a very interesting experiment, but I thought I'll put it in, not very related. So what they did is that they took some mice and they did a transplant, and from that they collected stem cells when they engrafted, and they did another transplant and implanted it in another mice, and it went on and on like that. And they could see that there is only one kind of stem cells which is surviving. So that is very interesting. So here, if you've got a myeloid one, you've got a lymphoid bias here. So there are the cells with myeloid bias, cells with lymphoid bias. You perhaps get both here. And if you don't get any, then you obviously get graft failure. So I just thought I'll put this in. So, in conclusion to this is that we really cannot accurately predict human stem cells, and we don't know which cells in the graft are really responsible for long and short-term recovery. And we think that the recipient hematopoietic cell, and definitely the bone marrow niche of the recipient, is very, very important in your VEGFs. For example, why does a myelofibrotic patient have graft impairment? It is because of the abnormality in the bone marrow niche, really. So your VEGF producing cells, your other ions, and they don't give a signal to the stem cells to come and get accumulation in the bone marrow. And when we believe in something without much evidence, that is called a delusion. And when we start believing in a crowd, we become cults. And if you really want to know the psychology of the cult, this is something which you do read volume 3, which is called Philosophical Delusions. And there we talk about King George III. He basically, and yet he used to believe in alchemy. And when they were using arsenic to turn all metals into gold, and actually it does. Whatever evidence we create is created on a belief. So something very, very interesting. And how many of us, we use it in allogenic transplant, some of us don't. And I don't think, the results in allogenic transplant matter very much to the patient. But we use it a little bit differently. We tend to use it only in patients who need desensitization. So in a haploidentical transplant, if your donor-specific antibody is very high, what we do is we use a regime of rituximab, plasma exchange, IVIGs, bortezomib, and what we do is we give one Buffy coat from the donor on day -1. Remember, the Buffy coat will have lots of antigens on the surface of the cells, and in your in the donor body, in the recipient body, there are lots of antibodies floating. So it is supposed to take care of those antibodies, those antigens. So that is the concept. So we use it on day -1, and this is some of this data here. But there was one patient who was very difficult here. This one was very difficult here, and the DSA level was very high. And it only got better when we used multiple, what should I say, Buffy codes. So that was a little bit difficult here. In fact, for this guy called Shujoy Ghosh, we even did a immunoabsorption column to get rid of the antibodies. The next belief is that you have got a myeloablative dose of radiation. Now, this chap went into a radiation facility at Belarus, and he was a cleaner, and the machine was left on, and he went into the facility, and he received almost 18 or 20 grays of radiation. He was brought to Russia in Moscow, and there they kept him alive with GM-CSF and IL-3 many years ago, and for almost 100 days, so 130 days he was alive till he died of an infection. And if you can look at the granulocyte, that really didn't go down very much. You can see that. Whereas the platelets went down and recovered. So if we can keep patients alive for long in a sterile environment, post myeloablative doses of radiation and maybe chemotherapy, we most probably don't need to do a transplant. They will recover. So that is another belief that Robert Peter Gale used to have, that there is nothing called myeloablation. So in our meetings at Hammersmith, when we used to say we are doing a myeloablative transplant, he used to get very cross. So there is nothing called myeloablation. You cannot say that. And this has been proved. Okay, but please don't go on this. This is something just to think about, especially for the juniors. Just don't go on this. ATG is another cult. That was a real cult. Believe me, before the haploidentical transplants came in, there was a cult which was European-based, which we really used to like our ATGs, whereas the American group, they never used to like the ATGs. So even for unrelated transplants, some of the centers never used to give ATGs, whereas the Europeans, especially it started from Italy, they started to give ATGs for every transplant. So they were kind of two cults. What is the other one? The other one is this thing which we do a conference on MRD every other year. And Prof was there, we were lucky to have her last year also. So MRD before transplant, is this a belief? So we will see that we really need MRD before transplant. If you have sequential transplant, and if you can do it, do we really need minimal residual disease before transplant? So my first experience was with this is Professor Jamie Kavanagh at the St. Bartholomew's Hospital, when I saw that this man is trying to take active leukemias into transplant. I said, man, what is he doing? So, we didn't have too much success in it, but the concept remains. Then at the Hammersmith Hospital, we tried the Flamser-Rick protocol, which was with amosarcan. Unfortunately, amosarcan is not available in India, and we are not able to do this kind of the regime there. But if you can look at the data, your leukemia-free survival is definitely better, and relapse is much less if you can do a sequential transplant. What do I mean by a sequential transplant? Is that you give a myeloablative, sorry, I shouldn't say myeloablative, I'm contradicting myself. You give a high dose of chemotherapy, and then give a few days gap, and then do a lower intensity transplant, maybe with a little bit of radiation, and at the same setting. So that is called the sequential transplant, and that is perhaps the way forward for the active leukemics. If you cannot get if you cannot get disease clearance before transplant. So this is we tend to do it. We have done around quite a few of them. For our sins, as you know, we get patients who are very relapsed and refractory, and especially for the acute myeloid leukemias, we tend to do this kind of transplants, we use clofarabine. And clofarabine is expensive, but it is well managed. So we use clofarabine as a high-dose treatment pre-transplant, give them 3 days gap, then do a lower intensity conditioning transplant. So we use that till last week. We have this report, which is very interesting at the Journal of Clinical Oncology. And I thought I really need to show you this. So they're giving high-dose melphalan, then giving a few days gap, and then doing this transplant. So, whereas clofarabine is costing me millions, my melphalan is going to cost me pennies. So isn't this interesting? This is perhaps the way forward. We really need to see, but obviously melphalan has its own TRM and also its own morbidity more than mortality, and we need to be careful about about mucositis and things like that. I would recommend that you put a nasojejunal tube in those patients before we start transplanting. And maybe busulfan, melphalan, and if you're going to do haplo, post-transplant cyclophosphamide, all that we need to think about as to how much can we go ahead. But this is a very interesting concept of using high-dose melphalan also. The next belief is GVL, separating GVL from GVHD. We know that both graft versus leukemia and graft versus host disease goes together. So can we separate graft versus leukemia from graft versus host disease? And we can, especially if you have this machine. This is called the Clinimax. This is Prodigy, and then obviously, this is Plus, and then you obviously have the Clinimax Prodigy. And you can then, what you do is to do a CD19 and the TCR alpha beta depleted transplant, and you can do all sort of things. So you can give back NK cells there, you can give back, memory DLI, donor lymphocyte cells, you can have some mesenchymal stromal cells and give back. So that gives you a platform for playing up with your immunotherapy. And in very relapsed refractory patients, if you really are going to do this kind of things, why give post-transplant cyclophosphamide at all? You can do this with this kind of a machine there, so you can do a sequential haploidentical transplant with the Clinimax, and I'm sure the results will be fine. We have done around 4 or 5 there. It becomes very expensive also at the end. So we've done around 4 or 5, and it's been satisfactory results. So as we were talking that we cannot identify stem cells with CD34, so do we really need a dose of CD34 positive cells? And if we look at some of the data, then there is there. But as we have been through that, if you even leave the patients are going to repopulate their marrow. So why do we really need a specific dose of CD34? Now I'll tell you a story. I had just come back from the United Kingdom, and I went to Chennai first. Chennai is this town in the south of India, and we were doing what we do, trying to do transplants, claiming to cure patients, when my neighbor, he was a vice president of Barclays Bank at that time, said that he's from Mumbai and he has got his auntie who is suffering from lymphoma, relapsed lymphoma, needs a transplant. I said, yes, why not bring her here? But they didn't go there, they didn't come to Chennai, they did the transplant at Mumbai itself, at Dhirubhai Ambani Hospital. And this gentleman was there who did the transplant, who supposedly didn't give too much of stem cells or CD34 positive cells, and the patient didn't engraft and died of an infection. And there was a big case, medico-legal case, and in fact, this doctor then went to practice in the UK. The patient's relatives followed them to the UK. Remember, Barclays Bank is from UK, and this chap was, so the doctor didn't choose the country very well, I'm sorry. If you'd have gone to America or Australia, you'd have been better off. But, so he lost his practice, lost his license to practice in the UK also. So with that, the conclusion is that even though patients might not need a CD34 dose, if you can keep them free of infections, medico-legally, we definitely need a CD34 dose. So please still continue your practice with giving a proper CD34 dose. What we do is we use plerixafor 4 hours before to all donors, even before allogenic transplant. And what it does is that it increases your blastic, your plasmacytoid dendritic cell in the graft. And also what it does is that it increases your CD56 in the graft. And these are the CD56 bright, and we enumerate. And initially we were not getting very much, but now we are getting quite a lot of CD56 if we are using the proper dose of plerixafor 4 hours before the transplant. And what it does is that it gives me a lot of NK cells in the graft. And that helps me in tackling infections. That gives me the graft versus leukemia effect till the T lymphocytes can take over. So we are writing down this data. The data is not bad. One of the things against this might be that we are getting a lot of immunological problems like HLH, like CRS in the transplants when we are doing this. So we have to be careful. This is something which is going to help our remission status, which is going to help the infections, but we have to be careful with the immunological problems. So whatever you do will have its pros and cons, and you really have to choose your patients very well. So, this more cells than a mouse. If you can keep an elephant in a sterile environment, maybe not. Okay, so we really need to be skeptical about the CD34 dose, but still go on. And with that, we come to the CAR T cell experience. And our CAR T cell experience, we have started now to use the ImmunoAct product, but what we have been using is a CD19 and a CD22 CAR. And both, my experience with that is that we are getting a lot of CRS compared to the only CD19 product which ImmunoAct is telling and giving us. But what we are seeing is that the patients are doing very well from their disease point of view. So we are getting a good amount of remission status. And you see these patients are multiply treated, 5 lines, 6 lines treatment. And we are getting quite a bit of remission status, though the toxicity that we are getting is quite high. And I must say that I am not very impressed with the hematotox score in predicting this toxicity. So each and every individual will have a different kind of hematological toxicity, and you cannot predict. And I don't think we have come to that effect of predicting this, especially with the CARs that what we have used. Some people might do it with their products. With the product that I have primarily used, the hematotox hasn't helped very much. What we have seen is in patients who have had, let's say, a lot of vascular inflammation. So somebody who has had very active ischemic heart disease, somebody who has got an autoimmune condition, they are doing much worse compared to patients who don't have that. But most of them are going into remission. And with that, with the toxicity, we find this very interesting case, which we have put it as a case presentation in ASTCT also this time. And this is a 52-year-old female from Myanmar. And we remember that she also previously had autoimmune thyroiditis, many other autoimmune features. And we treated her with a CD19 and a 22 CAR T cell therapy, grade 2 CRS, and later on it didn't get better with tocilizumab. We used anakinra. We started the ferritin started going up. We used ruxolitinib. So remember, when you get a little bit of hyperferritinemia, you're thinking HLH-like condition is working. Ruxolitinib is a good drug to use. But in fact, nothing happened here also. And when we looked at the bone marrow, she was severely aplastic. So we really thought that there was something else going on, and she was parvovirus positive. This is something, again, these are recommendations, but infections are there, but nowhere is, things like parvovirus or bad bacterial infections mentioned in such recommendations. CMV is mentioned there. What we did was we treated her with some growth factors, high-dose IVIGs, foscarnet, sirofovid. They use it in parvovirus infections in post-renal transplant. So that is, we thought, let's bring that concept in and give a foscarnet give a Cidofovir. We collect stem cells in each and every patient undergoing CAR-T, autologous stem cells. So we give that back also, but again nothing worked. MSC, mesenchymal stromal cells, did dampen the inflammation for a few days, but again the counts didn't go up. So supportive transfusions, but the cytopenias persisted. And this is a graph of the cytopenias. And then what we found is that when we did the flow cytometry, we found that NK cell clone. Now normally, people look out for a LGL clone, but we found a NK cell clone which was predominant, and we proved the clonality by doing an NGS which showed up a TET2 mutation. Remember, she is an autoimmune disease. Now people who are TET2 or DNMT3A or SXL1 positive, they do have more inflammation, and whether that is giving rise to autoimmune disease or whether this is because of the NK cell, or whether this TET2 is giving rise to an NK cell clonality, or is this the reason for each and everything, we don't know. So though we know about toxicities and there are recommendations that you have to use this drugs and that drug, you really need to sometimes go beyond those recommendations and think. And once you start doing that, you find out that there is something going on in this patient which can be treatable. So we started treating her with subcut methotrexate once a week, and now once in 2 weeks. Patient has done well from the white cell count and the platelet count. Platelet is recovering. White cell count has definitely recovered. I saw her yesterday, I think, or 2 days ago, and she's got a white cell count of almost 10 right now. So definitely out from that. But her hemoglobin is lacking behind. So whether she is getting a PRCA kind of a thing now with the parvo, we don't know. So that is something to look into. CAR-T are multifactorial. We have to consider viral causes, in this case parvovirus, immune dysregulation, clonal hematopoiesis, infection, disease relapse, all might stay together. You will not get segregated cases, all might happen together. But what you really need to is to compartmentalize each and every problem in your brain and then go ahead in a stepwise manner to treat such cases. So again, long-term monitoring is required. And as I said, that this field is so new, even in transplants, each and every transplant is unique. Each and every CAR-T cell is unique. So you really cannot have proper recommendations. I have had invitation to sit on a viral panel of the ASTCT, and I have refused because I really don't think I am qualified enough to recommend my experiences to other people to follow, because their cases and my cases will be completely different. But saying that, you wouldn't have literature if we don't do that also. So the conclusion is, each and every way, think about what you're doing, question yourself that, especially for my junior colleagues, question yourself that whether what we are doing is right or wrong. If you are lucky enough to have an educated guess which works, you are a good doctor. If you are not lucky enough, I'm sorry, you will not have too many patients. So that is the conclusion. And at the end, nobody knows anything. We just try to follow, we pretend that we know a lot and we try to follow that. Actually, we don't know anything. So thank you very much. And Sirish, if you're there, you want to say something?
No, Joseph, thank
And in very hyperprolesterolemia, you're thinking, it works, you are a good doctor if you're
myeloma and
unique. Yeah, whether this is because of the NK cell, but he's a very dear friend. So I think it's almost 10 right now. So definitely out from that. But her hemoglobin is lacking behind. So whether she is getting a PRCA kind of a thing now with the parvo, we don't know. So, but he's a very dear friend. So I think, we will get some comments from them before we go into questions.
Yes, of course.
Hello. So, unique. Each and every CAR T cell is unique. So you really cannot have proper recommendations. I have had invitation to sit on a viral panel of the ASTCT, and I refuse because I really don't think I am qualified enough to recommend my experiences to other people to follow, because their cases and my cases will be completely different. But saying that, you wouldn't have literature if we don't do that also. So the conclusion is, think about what you're doing, question yourself that, especially for my junior, whether what we are doing is right or wrong. If you are lucky enough to guess, to have an educated guess which works, you are a good doctor. If you are not lucky enough, I'm sorry, you will not have too many patients. So that is the conclusion. And at the end, nobody knows anything. We just try to follow, we pretend that we know a lot and we try to follow that. Actually, we don't know anything. So thank you very much. And Sirish, if you're there, you want to say something?
No, Jodip, thanks, and it's always interesting to hear you. I think it was a very enlightening presentation, a very different understanding, a different take on how we treat patients. So thanks for that. I think, Ravindraji, if you are okay, then we can open the floor for question and answers.
Before that, we have got two very eminent professors here, two very senior professors and one not so senior professor. So, but he's a very dear friend. So I think, we will get some comments from them before we go into questions.
Yes, of course.
Hello. Yeah, Professor, I will request your comment.
thank you for that. I have learned about, because of this is a new patient anyway for our hematological patient with the malignancy. But I absolutely agree with you, and because of our hematology is a very improving very fastly. Very fastly, immunology is a very changing a lot, and also a lot of updating and this immunology practice in the hematology. And this CAR-T cell therapy is what I am thinking about is, if it is good enough for this myeloma and lymphoma, so I'm thinking about that maybe in future CAR-T cell therapy may become the frontier or the earlier treatment for some aggressive lymphoma, rather than we start from our standard of therapy for aggressive lymphoma, just like double hit lymphoma or some very aggressive ABC type or something like that. Even without doing the other standard of treatment, we better to do the CAR-T cell therapy should suggest, should be treated for these people for the CAR-T cell therapy. I think that may be the future for our patient, because then we know the chemo-resistant lymphoma, whatever we give to this patient. So I'm thinking about some therapy should be there for these patients, earlier treatment. And also, I'm thinking about, so this CAR-T cell therapy is good for the B-cell lymphoma. What about in the T-cell lymphoma? So T-cell is a lot of diversity and then target is very difficult to get there. So maybe some our difficulty is that T-cell lymphoma leukemia is also challenging. So CAR-T cell therapy may be another future way for treating the T-cell lymphoma as well. But we are still learning, even though our hematology practice are a lot of changes, and I am still learning. And thank you very much for that. I have learned a lot from that. Yeah.
So I'll just put in that there is a lot of work going on in the T-cell lymphoma thing worldwide. Most companies are doing it, and there is a allogenic CAR which is almost ready. Some centers have definitely used it. In my center, what we have done is we are doing preclinical studies with T cells, along with two other government institutes, the Center of Biomedical Genomics, which is again in West Bengal, and there is also called NIPCAR, which is a pharmaceutical one. What we are trying to do is a CRISPR-Cas9 based, gene editing based CAR, this one, and this is going to knock off some of the genes, for example the CD52 gene, so you don't need any, so you won't have any graft-versus-host disease. It is going to knock off your TCR alpha beta gene. So some of these ways that it is being planned, preclinical, but there are other groups in the world which are much ahead in thinking of doing this, and definitely some of the trials have been published. One in NEJM you can see where they've done a CD7 CAR. So that's definitely one thing which we are there. So I think very soon we will have a CD7 CAR. Next one is whether we can treat aggressive lymphomas initially. Mr. Dunlon, if I have a double hit lymphoma today, I would say give me, suppress this, disease reduce, do me a CAR-T cell as soon as possible. I think, there are certain lymphomas, certain diseases where immunotherapy will work better than compared to other diseases. So we are learning that. How do we know about it? We really don't know, but maybe again, I would definitely recommend that a CAR-T cell company, if Suresh you're listening, that we do a gene expression profiling and NGS on all recipients and see that which patients are doing better, which patients are doing. It's going to be an observational study. It is going to be 3 years, 4 years. But that is the only way we can know that which patients are going to do well with CAR-T early on compared to. So that is one of the things which we are looking at. And yes, there are certain diseases where immunotherapy works. One of the other things which I think we haven't been able to completely elucidate is what we do post CAR-T. How do you take the patient post CAR-T? Do you need to expand the cells more in the body in vivo? Do you need to give any maintenance therapy? Do you want to augment the CAR-Ts? So I think again, that field, everybody is trying something or the other. We try something, some other places try something else. So sometimes you get it right, sometimes you get it wrong.
Now I will request Professor A.G. to say a few words.
I totally echo that sentiment, Dr. Jayati, because two things. I think it's a new area of treatment. So there is a huge learning curve. We now have insight into the 500 odd patients that we have treated, a whole host of international data, but still there is a lot of learning that is happening, especially in subset analysis. And you're also right that more diagnostics actually sometimes help in less treatment. So sometimes instead of flying blind, a little investment in the diagnostics, especially the NGS and new tools of NGS and now ctDNA, a couple of others, is also very, very important, to ensure that we get the right treatment at the right time. So yeah, agree with you.
Thank you very much. I'm Dr. A.G., the currently President of the Hematology Society of Mumbai. And first of all, I would like to congratulate ImmunoAct for introducing the very first CAR-T products in India and also in very early kind of pioneer in our region. And I'm very excited to learn from the information we've given, and at least it could provide some hope for some hopeless patients in our country, because most of the patients could not afford the prices which offered from other countries. So like rituximab, which saves a lot of lives in Myanmar after the products from the generic products from India has introduced, and likewise we hope that your products could save, at least could give some hope for at least some of our patients who could not afford the kind of products used in many other countries. Even before 2019, I've been offered from other countries about CAR-T, and they visited our center and promote their products, particularly from Malaysia. And even during past few years, I've received some promotions from China. But after having information from you, I'm quite hopeful of saving some lives or giving some hope for those in Myanmar with very high-risk disease. And first thing I would like to know is a logistic question. Do you think is it possible for us to use your product in Myanmar? Or I mean, it is for those who can afford, can go out of the country and can go to any places. We have already referred a few cases to India and some to Thailand. But what about your views on logistic aspects of using your products in the future in Myanmar?
Suresh?
Hello, Sirish, are you there?
Yes, Dr.
In Myanmar, so what I understand, once it is registered, then we have to work out logistic. How many months this is having expiry, this product? No.
So
3 months.
Shelf life
Is 3 months.
Shelf life is 3 months. Correct.
Yeah, then it can be work, because now we have a direct flight from currently we have direct flight to Kolkata, Chennai and Delhi, and as per my information, most probably there will be a once in a week direct flight from Mumbai also shortly. So if we have direct flight, we can get it, but before that we have to register this product with the FDA, and it takes in Myanmar minimum two years. But if we talk to Health Ministry and our current FDA director, DG is my friend, he is basically endocrinologist. So it may be shortened, but it cannot be get below 18 months, I think.
Yeah. I think there are two aspects of treatment, right? One is the current method where we are, of course, the patients are traveling, many patients under the care of Dr. Joydeep himself. Basis the recommendations from the treating doctor in Myanmar. Now over there also, I think there is a lot of joint work that can be done where because this is a treatment which is not a one-time infusion and then you are done, right? There are long-term toxicities involved. There is long-term care continuum. Dr. Joydeep was mentioning some of the combinations. Whatever capability we are building in Myanmar also, so that for every small post-CAR T treatment also, even once a treatment infusion is done in India, when we travel back, some of the treatment can be done locally so that there is understanding. So there is a little bit of joint workshops that we can structure availability. I think that is important. It's a lot of learning, and every case is unique. That is no different from bone marrow transplant, but in some cases even more complicated. Then long term, what we are suggesting is we develop a center of excellence, and in collaboration either with HCG and with your help, and then we can have a long term and the productive register. That could be a more long term plan. So this is how I look at it, and it has to be gradual, because again, in India we have learned that there is a huge learning curve that goes along with this usage. A lot of senior doctors, even on our panel also, we have continuous education. So we can structure. We are there to support. Whatever is good for the patient is good for us. So yeah, we can work on this.
Thank you, Siris. We request Professor Sanwin to say something.
First of all, I would like to congratulate ImmunoEd team and Mr. Sharif for your inspiring team trying to provide game-changing treatment for humankind at an affordable price. Secondly, I would like to thank Dr. Chadi for his presentation regarding the beliefs and his experience as a supporting the guideline formulation and reminding that the guidelines are being by which kind of professionals. And everything he presents is very enjoyable and enlightening us, and that's just my comments. Thank you.
Okay. Thank you. And anybody have any another question? Or everybody is feeling hungry? So now it is lunch time. And so Siris, thank you very much for taking out your time. We have made it that full video of this program, and we will be uploading on our YouTube channel. And like you know, our 4R consultancy is the exclusive partner for SCG Hospital in Myanmar. And thank you, Dr. Jaideep. It is with Professor AG and her team help, our relationship has grown, and now it's become very much synonymous for Dr. Jaideep and 4R.
He present is very enjoyable and enlightening us, and that's
Not
Good for us. So yeah, we can.
Dr. Jaideep and 4R4 hematology, and yesterday Professor AZ called me that they will going to a hematology conference. So their 4R and SCG will going to arrange that lunch CME, and whatever best we can do, we will do. And so
Good for us. So yeah, we can work on this.
thank you, Siris. We request Professor Sanwin to say something.
First of all, I would like to congratulate ImmunoEd team and Mr. Sharif for your inspiring team trying to provide game-changing treatment for humankind at an affordable price. Secondly, I would like to thank Dr.
All LDC countries. Like previously what India was doing, now Myanmar can do. But now India cannot do, because if India do any generic product, they have to pay the royalty, and once they pay royalty, then it is not viable. Yeah, thank you, Dr. Jaideep, for your next excellent presentation, or you have to say something?
No, so can we come out of the link? Sirish, all okay? Can we come out?
Yeah, thank you, Siris.
Thanks everyone.
We've got a flight to catch also.
Yeah, because Dr. Jaideep and Souvik have flight today. And before we go for lunch, I would like to invite everybody to take a one group photo for memory.
Okay, Immunac guys, thank you very much.
Or Immunac guy, if you can open your camera, we can take your picture also.
Thank you so much.
Okay, thank you.